Good evening to my professor, fellow classmates, and opposition. My name is Otessa Monks, and I will be debating against that all publicly funded palliative care or hospice settings be required to provide medical assistance in dying, which is most commonly referred to as MAiD. My position is that the provision of MAiD is a practice separate and distinct from hospice palliative care. While both help to relieve suffering, they do not share the same philosophy, intention, or approach to end of life, and its public funding should not be siloed. Hospice palliative care is used interchangeably with end-of-life care and palliative care. It has a long history that dates way back and long before our universal health care over 50 years ago. It takes a specific approach to care as well as a philosophy that focuses on providing relief of suffering as life and death take their natural course. It aims to improve the quality of life for those living with a life-limiting illness as well as their families by addressing their needs, hopes and fears, preparation for the dying process, coping with loss and grief, and promote opportunities for meaningful and valuable experiences. It does not seek to hasten death or intentionally end life. Medical assistance in dying became legal in Canada June 2016 for any eligible adult to receive assistance from a doctor or nurse practitioner to cause their death. The federal legislation sets out the eligibility criteria. MAiD is done through the administration of a substance to a person at their request that causes their death by a physician or nurse practitioner, or it can be self-administered of a substance that was prescribed by a physician or nurse practitioner and in doing so cause their own death. Since the legalization of MAiD, there's been a lot of conversation about what role this will have in palliative care, because vast majority of patients who are considering MAiD services also have palliative care needs. Hospices were forced to make a decision on how they were going to manage MAiD and service their communities, and whether or not to even provide MAiD within their institution. The federal legislation not only protects this decision, but respects provider rights as to not force any person to provide or help to provide medical assistance in dying. Not all healthcare providers are comfortable with medical assistance in dying, and participating in MAiD may not be consistent with a specific provider or institution's beliefs and values. This debate is not, however, about pinning hospice palliative care against MAiD or forcing Canadians to choose one or the other. They are different and serve very different needs of Canadians. It is to protect the rights of providers, preserve the long-standing history of hospice palliative care approach, and acknowledge the increasing needs of palliative care and the inadequate availability within Canada already, despite the current public funds. Canadians can access palliative care at home, in the hospital, long-term care homes, and residential hospices. There are 88 residential hospices in Canada that provide around-the-clock palliative care support in a home-like setting as an alternative to end-of-life home care for patients with complex needs. Majority of hospices require a patient to have a prognosis of less than 3 months to qualify, and we know that there is a shortage of beds available, resulting in upwards to 47% of patients dying while waiting to even be transferred to a residential hospice. This is the total deaths in Canada in 2016 and 2017, and I wanted to reference this to compare it to the relevant data within the same time frame that I was able to find. Of the 267,213 people that died in Canada in 2016, only 15% received publicly funded palliative care. Research suggests that between 62% and 89% of people who die could benefit from palliative care, and at least 70% of Canadians do not currently have access to palliative care. Patients that have requested MAiD and that are eligible can receive it in their homes, in hospital, long-term care homes, and in some participating residential hospices. In 2021, total MAiD deaths accounted for 3.3% of overall deaths in Canada. And of these deaths, the majority, 81%, received palliative care. And the recipients who did not receive palliative care, of 88% of them did have access to it. These statistics demonstrate that MAiD patients had significant higher chances of receiving palliative care and fulfillment of their end-of-life wishes with MAiD, despite not being offered in all publicly funded palliative settings, and even more so than a dying patient requesting access to residential hospice. Under the Canadian Charter of Rights and Freedom, everyone has the right to conscious objection and right to religion objection, both to religious beliefs and religious relationships, and the same goes for institutions and organizations. The law does not compel an individual to provide or assist in providing medical assistance in dying. The College of Physicians and Surgeons and the College of Nurses of Ontario both fully support physicians and nurses in choosing not to participate, but agree that this must be balanced with the freedom to obtain assistance in suicide, and therefore the provider not willing to participate in MAiD must complete a referral in good faith to another provider within a timely manner and continue to provide care not directly related to MAiD until a replacement provider is found. And the same goes for all other team members involved, including but not limited to the pharmacists and pharmacy technicians. Now, I will argue that there is a significant harm and ethical hazard in disregarding individual and institutional rights to conscientious objection. Now, let's consider for just a moment that the government chooses to take more action to ensure that all publicly palliative and hospice settings provide MAiD. Whether they choose to control this by reducing or canceling grants to the institutions that refuse to provide MAiD, or compelling providers to provide MAiD, we would see loss of staff, either voluntarily or involuntarily, and reduced services being offered due to staffing and lack of funding. It completely devalues medicine as a profession and treats physicians like technicians merely trained and just paid to do a job. Providers may even stop accepting patients simply out of fear of requests for MAiD. Enforcing restrictions on conscious rights is not only unethical, but it will result in worse service provision to dying patients. Just as someone may have a fundamental right to die, physicians and faith-based institutions should continue to have an equally fundamental right to govern their own actions, including exercising conscientious objections to MAiD. So in conclusion, the provision of MAiD is a practice separate and distinct from hospice palliative care. While both help to relieve suffering, they do not share the same philosophy, intention, or approach to end of life, and its public funding should not be siloed. Coercion of providers or institutions to participate in MAiD that goes above and beyond just a referral in good faith is unethical and definitely unjustified. Well, this is it for now. Thank you for listening. I am looking forward to the rebuttal already and participating in further discussions with you all.